Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Hilary Tungal. Today's episode features Dr. Jean-Michel Molina from the University of Paris-Cité in Paris, France, and Dr. Joseph J. Eron from the University of North Carolina at Chapel Hill in North Carolina. They'll discuss the results of key clinical trials on HIV prevention and treatment, as well as STI prevention presented at IDWeek and Glasgow 2024. For more information on Drs. Molina and Eron, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about this important topic.
Hello, good afternoon, everyone. It's a pleasure to be here with you today. And I'm going to go through the first studies presented in Glasgow on HIV prevention. Again, the focus was put on the two purpose studies, these studies assessing twice yearly lenacapavir injections versus daily oral TDF FTC or TAF FTC for HIV prevention. In that study, people were enrolled in the study were cisgender women, young women in Africa, were sexually active, who had not been tested for HIV recently and no prior use of PrEP or PEP in the last 3 months. And they were randomized in 3 different arms: lenacapavir subcutaneous injection twice a year, daily oral TAF FTC, daily oral TDF FTC. You probably have seen the results published in the New England Journal of Medicine a couple of weeks ago. And this analysis today was focused on the persistence and adherence to lenacapavir as compared to daily oral PrEP. And if we look at the definition of persistence on lenacapavir, the definition was on-time injection at baseline at week 26 and to be on time for the follow-up visit at week 52. And when you look at the rate of persistence with lenacapavir injection, it was 91% at week 26, 94% at week 52. And this rate was actually similar in people receiving placebo injection in the 2 oral PrEP arms. And if we look now at the persistence in a pre-selected 10% sample of the participants, the persistence with the injection was similar whether people received lenacapavir or the oral PrEP agents. Then the idea was to compare the adherence to oral pills, and we know that oral adherence to the pills was low and declined over time when we looked at tenofovir diphosphate level in a dry blood spot. And in addition, they did match case control study looking at the risk of acquiring HIV infection according to adherence measured again by the level of tenofovir diphosphate in DBS. And there was actually a lower chance of acquiring HIV infection when you had a medium or high adherence to oral pill, and the trend was quite strong. And those who seroconverted with the oral pills are declining adherence. If we now look at the persistence comparing lenacapavir injection to oral pills, with lenacapavir injection, the annual persistence was 79.5%. It was only 5.25% with oral pills. So there was here a very strong difference in persistence according to the definition used in that study. Let's move to purpose 2 now. With a similar design, although there was no TAF FTC here, the comparison was between lenacapavir injection and oral TDF FTC. That study was conducted among cisgender men and transgender women, also transgender men. Again, the primary endpoint was comparing the incidence in the 2 arms versus the background HIV incidence. And the interest of this new presentation of purpose 2 was to provide more information about the global racial, ethnic, and gender diversity in participants of these purpose 2 study. In terms of geography, most participants actually were enrolled in South America, in Brazil, Argentina, Mexico, also in the US, Thailand in particular. When you look at race, 38% of the participants were Black, only 33% white, and 63%, as expected since the study was conducted mainly in South America, were of Hispanic ethnicity. In terms of gender, 78% were cisgender men. So overall, 67% of the participants came from racially minoritized Black, Indigenous, or people of color. and 22% of the participants were transgender or gay non-binary. Here you see the purpose 2 outcomes in terms of HIV incidence. As you may know, the incidence with lenacapavir was very low, 0.10 per 100 person years of follow-up, with only 2 individuals who had acquired HIV infection during the study. The incidence with oral TDF-FTC was also lower than the background HIV incidence, with only 9 individuals getting infected. What was interesting here is the incidence rate ratio comparing lenacapavir to the background HIV incidence or lenacapavir to TDF-FTC, which you show favors very significantly lenacapavir. But to get more insight in the 2 people who were infected in the lenacapavir arm, although there were only 2 individuals, it was interesting to see that these 2 individuals actually developed resistance to lenacapavir at the time of infection with pretty high viral load. So we could come back to that in the discussion. And indeed, when you compare the incidence of HIV infection with LEN versus daily oral TDF-FTC, you had an 89% relative reduction. So a strong reduction of HIV incidence with lenacapavir also in this population of cisgender men. I will turn it over now to my colleague, Joe.
Hey, thanks, Jean-Michel. So I'm going to talk about 2 observational studies from that were presented at IDWeek. The first is from the TRIO Health Cohort, and this is looking at long-acting cabotegravir as PrEP in a clinical setting. So this is an observational cohort distributed around the U.S. So these are from 12 health centers around the U.S. They used the electronic health record to evaluate kind of persistence, adherence, efficacy, and safety of this long-acting PrEP over the first 2 years of use. And the people in this cohort where the data were extracted from obviously had to be without HIV, weigh more than 35 kilos, and they had to have a long-acting cabotegravir prescription in their database. And also, they specifically did not include people who had been on a clinical trial for long-acting cab. And in this 2-year period, they have 526 people. Median age was 32. A third were Black, and a small percentage, but some were female, 72 or 14%. And importantly, a lot of these people, 70%, were experienced with PrEP, so with oral PrEP, before they decided to go on to the long-acting PrEP. In this particular cohort, the median follow-up was 7 months. And over that follow-up time, 18% discontinued, and we'll talk about that in a second. They had no seroconversions in the first 12 months after the discontinuation of the long-acting cab. Some were retained in care. Some had switched back to oral PrEP. About a quarter of all that discontinued or so, but some also stopped using PrEP. And then some went on to reinitiate PrEP, and not surprisingly, about a quarter lost the follow-up. When looking at delayed injections, that second injection, remember the first 2 injections are separated by 30 days. They're about 16% delayed, that second injection. And about a third sometime after that second injection, so 3rd, 4th, 5th injection, had a delay, though the median delay was short. But delays in injection certainly do occur. This next slide gets into the HIV testing. And I think everyone knows that the CDC guidelines recommend both an antigen antibody test and an RNA before each injection. So 56% had a antigen antibody 100% of the time, meaning before the first injection, before the second injection, before the third injection, et cetera. But only 34% had both an antigen antibody and an RNA 100% of the time. So most of the time, the CDC guidance was not followed. There were few injection site reactions that led to discontinuation, which is very similar to the clinical research studies. And there were no HIV seroconversion episodes. But as you might guess, that with slightly more scattered testing, seroconversions may not be picked up as quickly as they might have been in the clinical trials. OPERA is another observational cohort. They collect their data prospectively. This is over approximately an 18-month period. Baseline characteristics of age, sex, race, and ethnicity were matched between people who chose to go on long-acting PrEP and people who were on oral PrEP. And the things they looked at were late initiation or late dosing. They also looked at testing patterns and also HIV acquisition. And they looked at this compared to the CDC guidelines. So complete initiators are people that got the first dose and then got the second dose within 60 days, right? So it's supposed to be at 30 days, but within 60 days, you don't have to have an extra injection, et cetera. And that happened about 85% of the time. So 15% of the time, people were outside that 60-day window. So again, it's a challenge to do things perfectly. And then if you look at on-time injections, you can see that, again, about a third of people, a third of the injections, who people had complete initiation, about a third had some delayed injection. Some it was the second injection. Some it was a later injection. Delayed injections were more common with the later injections, I think because there were more of them. And some people, by definition, required a reinitiation. So if your second injection was if your injection after initiation was delayed by more than 90 days, so 91 or more days, you were supposed to receive an additional injection. Only a minority of those people did. And it's not clear to me anyway, whether that's because people discontinued or because they just didn't get that required second booster injection. So this is really, an important point that kind of operationally, it's hard to do things perfectly in the quote real world. And then much like in the TRIO cohort, only 65% received HIV testing at initiation, which to me is kind of shocking. That's kind of a shocking number. But to be at initiation, it had to be within a few weeks of the actual injection. So I could see where there probably was testing, maybe more remote than that. And 50% received HIV testing at all subsequent injections. And again, very much like the TRIO cohort. Unlike the TRIO cohort, this particular cohort had 2 seroconversions. Case 1 is for a person that was on FTC-TAF for 70 days and then received LA-CAB 3 injections, but there was no HIV testing at the time of when LA-CAB was initiated. So we don't really know that this person became infected, acquired infection while they were on LA-CAB. We only know that on day 92, their antibody was positive and there was not enough virus there to genotype, which again contrasts to what Jean-Michel said about a potential seroconversions on lenacapavir. The second case is really kind of a typical one on FTC-TAF for 65 days, had 4 injections, and then while actually getting the injections was tested negative, and then had no PrEP for 130 days. And when they restarted, they were found to seroconvert 9 days after starting FTC-TAF. And that person had no resistance, which is actually kind of typical. And it's interesting. We worried about covering the tail of long-acting cabotegravir. As far as I know, that hasn't really been a problem. I'm not saying it won't be, but it hasn't been either in clinical cohorts or in the clinical studies. And then a different presentation looked at kind of giving long-acting CAB in a community pharmacy setting. And this is 24 weeks of analysis. These are surveys of people who were receiving injections from community pharmacists. So this is not a survey of the pharmacists. It's a survey of the people getting the injections. At least in this setting, almost all people agreed or strongly agreed that they were comfortable receiving PrEP injections in this setting. Again, almost all of them felt they were well informed and they were motivated to start therapy in that setting. Interestingly, that no one agreed that they would be ashamed if people knew they were on long-acting PrEP. I don't know that that's a consistent finding in a larger sample, but that's what was found here. And then most of the people persisted, and in this community setting, 94% of the injections were on time, which is really terrific. So I'm going to summarize, and Jean-Michel may want to jump in. In Purpose 1, persistence was significantly higher with twice yearly len versus oral PrEP. In Purpose 2, it was very racially, ethnically, and gender diverse, which is great, kind of allowing us to understand how long-acting len will hopefully work in communities that are disproportionately affected by HIV. It is important to note that in Purpose 2, unlike Purpose 1, there were 2 seroconversions. I think both TRIO and OPERA showed that long-acting PrEP was very well tolerated, with rare instances of seroconversion. And in fact, the 2 that we described are really, one was delayed and one might have happened actually before the CAB started. But the testing did not really fit CDC guidelines. I'm not sure it's suboptimal testing because I'm not sure the guidelines are optimal testing. Maybe it's the best, but really it's very hard to implement in any kind of real world program. And then this small but interesting study on longitudinal long-acting PrEP in a community pharmacy setting really demonstrated that this approach could be feasible and maybe a way to get people to be retained on long-acting PrEP. So I'll stop there. Jean-Michel, do you want to jump in with anything?
Thank you, Joe. Well, I think you summarized it very well. I think the data on persistence show that the difference between lenacapavir and oral PrEP and the difference in HIV incidence is mainly driven by a difference in adherence, not by the efficacy of the regimen, of the antiviral activity of these drugs, but really mainly by the adherence. And the study design, double-blind, double placebo, also in some way would favor non-adherence to the pills because everyone received an injection, and then you may think that you are receiving an active drug, and therefore, there's less incentive for you to take the pills between the visits.
Yeah, and I do think, as you point out, in Purpose 2, slightly different than Purpose 1, TDF-FTC was actually effective. There were only 9 infections and that they didn't pre-specify to compare it with the background incidence. It certainly appeared to be lower. So I think your point is well taken. If you take the pills, they work, but that's just a challenging thing for people to do day in and day out.
And especially for young women, because when you look at adherence to the pill using, tenofovir diphosphate in BBS, adherence was much better in cisgender men in Purpose 2 than in young women in Africa in Purpose 1. And so that explained also why you have these differences in incidence between the 2 studies with the oral. Okay, so maybe let's move away from PrEP for a moment and go back to treatment of HIV infection. And in Glasgow, there was an interesting study, new data presented by Pedro Khan. You may know is the first who introduced the concept of dolutegravir 3TC as first-line therapy for people with HIV infection. But in most guidelines, there is a warning if you want to use this combination first line, is that the data in people with CD4 cell count below 200 are less compelling. And that's why this study was designed. It was a multi-center open label study to assess this dual therapy, dolutegravir 3TC, in people with HIV naive to treatment. People were enrolled mainly in Argentina and Brazil. They were negative for HBs antigen. They had a CD4 cell count less than 200 and an HIV RNA above 1,000 copies. The randomization was stratified by country and by HIV RNA level at screening below or above 100,000 copies per ml. And people were randomized 2-to-1 to either dolutegravir 3TC, QD, or to dolutegravir TDF, FTC, or 3TC, QD. The primary endpoint was the plasma HIV RNA level at week 48, below 50 copies per ml, using the FDA snapshot analysis in the intent to treat exposed population. Let's look at the results. So first, maybe the baseline characteristic of the patients. Interestingly, you could see that the baseline viral load was pretty high in these naive people with, it's expected since the CD4 cell count was pretty low, below 200. You see that the median HIV RNA was about 5 logs in both groups, with a significant proportion of people with more than 100,000 copies per ml, 61%, again, in both arms. And if you look at the median CD4 T cell, it was 109 in the dual combination arm, 128 in the triple combination arm, with roughly 40% of the population below 100 CD4 cells at baseline. So let's move now to the efficacy at week 48 using the FDA snapshot analysis. When you look at the intent to treat exposed, 82% of people randomized to dual therapy versus 81 to the triple regimen were suppressed, with a difference of 1.7 and a confidence interval between minus 8.3 to 11.7. And when you look at the per protocol analysis or in the intent to treat exposed analysis in those with a high viral load above the 100,000 copies per ml, and we can look at this difference because, again, randomization was stratified on this viral load. Again, you could see that 81% of those randomized to dolutegravir 3TC were suppressed versus 77% with the triple regimen. So that was quite unexpected. The difference was 4.2, and the confidence interval ranged from minus 9.5 to 18. So a pretty large confidence interval because the number of participants was quite low. So clearly, we could just say that the rate of suppression was similar also in those who had viral load above 100,000 copies per ml. Another way to look at the data is to look at the efficacy at week 48 according to the baseline viral load in those who had higher than 100,000 copies per ml. This is no longer a randomized comparison, but it's interesting to look at the numbers. And you could see here again that in those with viral load above 500,000 copies, 74% in those receiving the dual combination versus 67% in those receiving the triple combination were suppressed. And if you look at those with 1 million copy at baseline, again, 63% suppressed with the dual combination versus 57% with the triple combination. And when you look at those with virologic failures, 7 with the dual combination, 4 with the triple combination, but remember that the randomization was 2-to-1. There was no NITI or INSTI resistance that could be identified. So pretty good results for this dual combination, although it's a limited size study. When you look at the safety now, as expected, in terms of treatment-related adverse events, very similar rate between the two arms. Also, in terms of serious adverse events, there were 2 deaths that were said to be treatment-related. One in the dual combination arm with pancytopenia and fever, and the other one in the triple arm with tubercular acidosis and bronchopneumonia. It remains to be certain whether these are really treatment-related deaths. And if you look at the rate of iris, again, it was very similar across the 2 arms.
So I'm going to talk about a study that is dealing with a therapy that's not yet available. So this is a research study, and it's talking about once weekly islatravir and lenacapavir. People may remember that islatravir is a NRTTI, so it blocks reverse transcription in 2 different ways. So it's an extremely potent drug. And in this particular study, it was an open label, active control, randomized design. These were people that were on bictegravir TAF FTC and suppressed. They had to have a CD4 count greater than 350, and they were randomized 1-to-1 to either have just once weekly treatment with islatravir, lenacapavir, or to stay on their bictegravir TAF FTC. And what we're seeing for the first time is the 48-week data. And when each participant reached week 48, they then were allowed to go on once weekly therapy. And as you might expect, the primary endpoint is of HIV RNA greater than 50 at 24 weeks by the snapshot analysis. And these are the data. I think most of the individuals maintain suppression. You can see 94% with the once weekly, 92% versus continued BF TAF. And importantly, there were no participants that had an HIV RNA greater than 50 at week 48. And most of the other folks were people that just had no data in the window. Adherence to therapy in each arm was excellent. And there were 2 discontinuations in the islatravir lenacapavir arm unrelated to the drug. There was a discontinuation for another reason unrelated to the drug. And there were people of those 3 people who discontinued, all were less than 50 when they discontinued. So essentially everybody on the study maintained their viral load less than 50, either at week 48 or when they stopped. Importantly, people may remember that there was a once-weekly study with a higher dose of islatravir where there was a decline in lymphocyte counts and a decline in CD4 cell counts. And in this study, there were no significant differences in the change in CD4 over time or the change in lymphocytes over time between the continued BF-TAF versus the once-weekly. There were no 3-4 AEs, no serious AEs, and no clinically significant abnormalities, except there was an ALT elevation in the islatravir lenacapavir arm when someone actually acquired hepatitis B, which is a little note. The phase 3 studies of this particular combination, islatravir lenacapavir, are either starting or about to start. So this particular combination is going forward with further development. We also saw the use of a combination of long-acting therapies. This is actually long-acting cab-rilpivirine plus lenacapavir. And people who have HIV have had adherence challenges and either had integrase or NNRTI resistance mutations. This is a case series. It's not a randomized trial. Please note there are only 9 people in this case series. On the other hand, this is an important intervention for people who are having difficulty maintaining suppression and have resistance to either cabotegravir or rilpivirine. And there were 9 participants here. All were Black. 6 out of the 9 were female. 1 patient had integrase RAMs. All of them actually had rilpivirine RAMs. Curiously, 1 actually had looks like resistance to both CAB and rilpivirine, though the mutations that were considered CAB RAMs really don't have a lot of impact on cabotegravir. And at somewhere between 24 and 36 weeks, all participants were less than 200. And those participants with a CD4 less than 200 when they started had a substantial increase. So obviously a successful intervention in a small number of people. Then at Glasgow, there were a couple of assessments of the literature looking at cohorts, observational cohorts. The first one was virologic failure and resistance emergence. This was 13 cohorts covering almost 3,000 participants, and they included virally suppressed people at start. Okay, so this is people who are kind of going on CAB, rilpivirine, as recommended. And the definition between cohorts varied, but for the most part was HIV RNAs greater than or equal to 200. Virologic failure definitions, again, very similar to the clinical trials, maybe a little bit higher, somewhere between 1% and 6.7%. The presence of resistance was variable. There were a couple studies that reported no RAMs in all the people that had virologic failure. There were just 2, and they had very small n's. Most of the cohorts reported resistance in either all the people that had virologic failure or some of the people had virologic failure. So certainly in my practice, virologic failure has a high likelihood of also being associated with resistance. Again, that's my opinion. And then this is looking at what happens after virologic failure. This is another systematic review of the literature. This is looking at phase 3. These are actually looking at research studies, and also 7 research studies and 7 observational cohorts that reported post-virologic failure outcomes. And again, the definition was this greater than 200. So across these multiple cohorts, in the treatment cohorts, 30 people experienced virologic failure. And again, 90 to 100% of the people resuppressed. Most used PI-based regimens. And then across the observational cohorts, 50 people experienced virologic failure. Again, a little bit more variable. 70 79% to 100% resuppressed. Interestingly, in those cohorts, most of the therapy was actually continuing on long-acting cabotegravir and rilpivirine. And really, I think this kind of needs to be dissected, and we need to look at this very carefully. So I think really interesting results. I think the DOLCE study, as Jean-Michel presented, really, I think demonstrated that people with low CD4 cell counts can be treated with dolutegravir 3TC. And your confidence is really going to be based on that sample size, which is 150 or so people who got dolutegravir 3TC. I think the once weekly islatravir lenacapavir study is really exciting, and I'm excited to see the phase 3 studies get going. I think with the cab rilpivirine len in people who can't maintain suppression on all therapy and have some resistance, I would say those 9 people suppressing were mostly people with NNRTI resistance. I'm not sure how this would turn out if someone had high-level integrase resistance. So think about that. And then I think our observational data suggests that treatment-emergent resistance with cab rilpivirine is infrequent, but occurs commonly when there's virologic failure, in my opinion. So I'm going to stop there and turn it back over to my friend and colleague.
Thank you very much, Joe. So let's move to the next topic, presented at Glasgow, which was about STI prevention. And the study was conducted in Spain. It was called the PRIDOX study among men who have sex with men using PrEP and at high risk of sexually transmitted infection. As you know, there have been now 3 randomized trials among men who have sex with men on PrEP or living with HIV that have showed that the use of Doxy post-exposure prophylaxis, 200 milligrams, 24 to 72 hours after sexual intercourse without a condom, reduces significantly the risk of STIs. And that study is not a randomized trial, but it's a prospective cohort study in people using DoxyPEP in a PrEP cohort of men who have sex with men in Spain. 189 individuals were enrolled in that prospective cohort. 38.8% used chemsex. They had a pretty large number of sexual contacts per month. 35.4% had more than 10 sexual partners. And you could see that the use of condom was quite low. You had the incidence rates per 100 years of follow-up of the first episode of each STI, either during the pre-DoxyPEP period or during the post-DoxyPEP survey, which was about 10 months. And you could see that the chlamydia incidence dropped from 31.8% to 8.53%, very significant decline. Gonorrhea also, its incidence declined from 41.7% to 26.6%, so it's somewhat lower in terms of decline, consistent with the results of the randomized study, but the difference is still significant. And syphilis as well, and that's important. There was a very significant decline in the incidence of syphilis from 21.6% to 2.5%, and this is highly significant. And I think these data are consistent with the results of the randomized trials and may partly explain why in the recent CDC statement, looking at the data from 2023 in the US, showed that there was a small increase in new syphilis cases after years of double-digit increases. And what's more important is in this report, there was a decrease by 10% of primary and secondary syphilis, and even 13% among men who have sex with men. That was the first time in 15 years that we've seen such a decline in men who have sex with men in the US regarding syphilis. And, it's unclear how to explain this decline, but it could be related to either, a better awareness of syphilis, an increase in testing, and potentially also to more widely use of DoxyPEP in these men. So the main takeaway from the PRIDOX study is that DoxyPEP reduces the incidence of STI in those men at high risk for STIs. And, we probably will see in the future more and more data from real-world cohort studies, supporting these results.
Yeah. Hey, Jean-Michel, a lot of these questions are for you. with your expertise. So I'm going to let you take off and answer some, and then I'll jump in.
Sure. Let's start with a question on the DOLCE study. And indeed, these data were new. So that was interesting to have a study addressing this question about this dual combination of dolutegravir 3TC in people with less than 200 CD4 T cells. And in the inclusion criteria, I did not mention whether or not people had a genotypic resistant test. And that was the question about whether or not people were screened for genotypic resistance before being enrolled in the study. And in fact, the study was again conducted in Argentina and Brazil. And in those countries, usually you're not able to get the genotypic resistant test before you start treatment. We may ask this question directly to Pedro Kai, but I'm pretty sure that they didn't do a resistant test. It's also true that the rate of primary resistance in naive people to dolutegravir or 3TC is very low. So it's probably very unlikely that there were anyone or very few individuals with resistance to either dolutegravir or 3TC in that study, not to mention tenofovir. So I don't think this has a major impact. I think what was really important was to exclude those who had HBV co-infection, probably, and with this combination, although in the guidelines, it is indeed recommended to test for resistance before using this dual therapy. I think in naive people, I'm not sure this is absolutely necessary. What do you think, Joe?
Yeah, I agree with you. There's a question a little further down about regarding the findings of the DOLCE study. Are you willing to treat advanced infections with double therapy? And so I'll answer that question in the context of what you just asked me. I don't feel a strong compulsion to use double therapy for initial infection. I'd like to start people as soon as I can. I think the data on switching to a double therapy is so strong that if you have someone with a CD4 of 50 or 60 or, and they have, pneumocystis or some other infection, I would still start them with triple therapy. Personally, I get these are good data. I'm not arguing with that, but they're asking my opinion. So that's what I would do. And I think if the person had substantial renal dysfunction or something and you only had TDF, then maybe that would be a different situation. But I'm curious, maybe you do something different, Jean-Michel.
Well, in fact, no, I would agree with you. I think it's reassuring to see those data in people with low CD4, because if you want to switch, for example, people well suppressed but still have low CD4, I think these data are reassuring that a dual combination will probably be as good, but I'd be a bit reluctant indeed at this point to start someone on dual therapy, because you need to get the HBV test also back, and so you may defer initiation if you want to use this dual combination, and also when you choose a regimen, you have to take into account as well what would be the benefit of using this dual combination versus a triple combination. And I don't see any benefit in using this dual combination first, except if you were not able to check the, GFR, for example, and that, but we know that, tenofovir is quite safe in combination with DTG, probably except in people who have a low GFR below 50 or 60 ml per minute. So, well, I think, again, these data are interesting. I didn't expect such a high response rate in people with low CD4 and high viral load. So I think it's good to have these data to support the use of this dual combination. At this point, I would favor also this combination for the switch to people well suppressed.
There are a bunch of questions about DoxyPEP. Maybe I should defer to you on those, Jean-Michel.
Okay, well, a couple of questions of DoxyPEP. So I agree with one of the comments saying that what about the long-term benefit of this strategy? Will it work forever? I don't think so, indeed, especially for gonorrhea. We know that for gonorrhea, any antibiotic that you would use would select for resistance. And we have seen that with Doxy in the different studies, that using Doxy, you would select for more resistance in gonorrhea, which at this point doesn't seem to be such a problem because we don't use Doxy to treat gonorrhea. The issue would be whether it would select additional resistance to gonorrhea for third generation cephalosporin, for example. And at this point, we haven't seen any signal, but we need to continue to monitor that. Regarding syphilis and chlamydia, as you know, there are no resistance so far. But again, we need to be cautious and monitor what we're doing. So I think on the short term, the strategy works very well, and we have followed now for 1 to 2 years. But beyond that, we still don't know, and we have to be careful in the way we use this strategy, and probably try to refrain very large use and try to select the best we can people who would benefit the most from this DoxyPEP strategy.
There's a question, Jean-Michel, about women. Are they being left behind? Maybe you could comment on that. I know the answer, but you know it better than me.
Well, again, there has been only a single large phase 3 trial assessing DoxyPEP in young women in Africa using oral PrEP. Adherence to oral PrEP in young women in Africa is very poor. So was the adherence to DoxyPEP when the study was completed. And although they didn't see any evidence of a reduction of STI with DoxyPEP in that study, part of the explanation is that indeed adherence to DoxyPEP was very poor in that study, with less than a third of the women having detectable doxy in their hair. In addition, there was only a single case of syphilis in that study, so you couldn't really assess the impact of syphilis. And regarding gonorrhea, all strains in that study were highly resistant to gonorrhea. So if you are in a country, in a region where very high rate of high level of gonorrhea resistance to tetracycline, you would not expect any benefit. So the efficacy of this strategy is probably also dependent on the rate of resistance in the different countries. However, when you look at PK in these women with DoxyPEP, you reach very high concentration in both the female genital tract, in the rectal tissue in women for more than 48 to 72 hours. So it should work as well in women. And as a matter of fact, at the AIDS conference in Munich earlier this year, there was a small study conducted among female sex workers in Japan, showing that with the use of doxy, they had a strong reduction of syphilis and chlamydia. So to really know what's going on in women, there is an ongoing study assessing, again, DoxyPEP in women, and we probably need to wait for the results of the study to use DoxyPEP more widely in women. But at this point, I think we have enough data to maybe use it on a case-by-case basis in women at very high risk.
Yeah, thanks, Jean-Michel. There's a question about long-acting CAB. I assume long-acting cabotegravir becoming a standard regimen overall for people without HIV treatment adherence issues. So the way I would phrase that, Orbit, is basically, I think long-acting cabotegravir is one of the standards now, at least in the US for sure, and Jean-Michel could talk about in Europe, for people who are suppressed on therapy. And the goal is to give people choice of what fits best in their life, because what fits best in their life is what they're going to be able to sustain in terms of adhering to therapy. So I think it is a standard. I don't think it's the standard. Many people are uninterested in getting an injection every 2 months. Some of my patients come in once a year now and would definitely not want to come in every 2 months to get an injection. Now, if they could get it closer to home or in a pharmacy, that's a different question. I think it's not a simple injection to do. It has to be in the butt, basically, and it has to be given in a specific way. So that it takes, I think, training to do it correctly. But I do think if it was people were able to get it closer to home, they might be happier about being on injectable. But some people are very much interested, persist in taking it, and it is really the right thing for them. So I don't know in Europe. In our clinic, I think we're almost like 10% of our patients are now on, we have almost 200 people out of our 1,800 people who are on long-acting cabotegravir. So it is clearly a standard in our clinic, not the standard, but a standard.
Right. It's about the same in Europe. I would say the issue for wider implementation is really a logistical issue to organize the first injections, because the approval in France and in Europe is to give a thirst-free injection in the hospital clinic, and then they can go to a private nurse for the following injection. So it's quite of a challenge to organize the clinic to provide these first free injections for a large number of people. But I would say that those who are on this regimen doing well, are very happy about that, and that changed their life, and they feel much better. And then some of them now, after 2-3 years of long-acting injectable, I see them only once a year, and not more frequently than those using oral treatment. And I think people who are facing stigma and discrimination of using pills or taking pills, and want to have their HIV infection remaining, very to keep this information very private. They want to share it with their friends, so it's quite a very good option. So I think it's really helpful for a number of people.
And Jean-Michel, if you have time, there's a very sophisticated question right at the end. And I've had that question too, and I can't remember which study actually noticed this relationship between doxycycline resistance and cefixime resistance.
That's an interesting point. This is an analysis that we conducted in our trial called DoxyPEP, which has been now published, but these data on resistance have not been yet published. They are, being written now. We looked in details at the resistance of gonorrhea to all different antibiotics, and we've seen a signal regarding cefixime where, there was a higher rate, not of resistance, but reduced susceptibility to cefixime in people in the DoxyPEP arm as compared to those in the no DoxyPEP. This difference is based, this high reduced susceptibility is linked to a PEN-A allele in the target of the antibiotics. And this allele actually, when we looked at more samples, looking at the genetic determinant of resistance, we couldn't confirm that finding, which was identified looking at the results of the cultures. Phenotypic resistance, I would say. When you look at the genotype, we didn't see that. But what was true was that those strains who had a reduced susceptibility to cefixime also had, for most of them, not all of them, high-level resistance to tetracycline. So there are probably some clones of gonorrhea that are circulating that carry both the TETM gene associated with high resistance to tetracycline and a PEN-A allele that is also associated to a reduced susceptibility to cefixime. We didn't see any resistance to ceftriaxone, for example, but these type of studies are important to continue to do to really monitor closely, resistance to gonorrhea, and whether or not using doxycycline would promote resistance to a third-generation cephalosporin, which would be a harm, really. At this point, it would be premature to say that there is a strong signal. There is something we need to monitor. That's what we could say at this point. But not other antibiotic was affected at this stage.
Okay. Looks like we've answered most of the questions. I'm pretty happy. Jean-Michel, how about you?
Yes, me too. That was interesting. And I would say the two recent conferences, IDWeek and Glasgow, provided us with additional data to better understand what's going on, and in particular with the prevention of HIV, the use of long-acting in general for treatment and prevention. And I was, interested to see, more data with lenacapavir for prevention. And I think we need, again, to better understand what's going on in the few individuals who had breakthrough HIV infection. How come these people were not protected by lenacapavir, for example? So I think the future will tell us, and we will learn how best to use this prevention tool.
Thank you, Drs. Molina and Eron, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, please click the link in the show notes, and be sure to check back regularly for more episodes on important infectious disease topics.